My name is Sanjeev Bhalla, and I'm a professor of radiology at Washington University, and I run the cardiothoracic imaging section here at the Mallinckrodt Institute of Radiology in St. Louis, Missouri. I think one chronic problem or issue in chest radiology is trying to distinguish, is somebody having a treatment-related effect or is a cancer progressing? And so, especially with radiation therapies, where we routinely follow up patients, this can become a real problem of knowing, is the cancer getting worse, or is this in fact an expectation from the radiation therapy alone? To answer the question the best, it's useful to know what kind of radiation was used, because if you know that what the port that was used, and if you know whether it was a single beam radiation therapy or a gamma knife or some sort of variations of radiation therapy, that will impact what we see. But as a general guideline, what we tend to see in many patients is we will see areas of ground glass in the months that will follow the radiation therapy. And then oftentimes it will result in some volume loss and minimal fibrotic change that's barely perceptible, and then we're done. And patients are usually asymptomatic, and that's all we'll see. A clue to that as being radiation is it'll follow the port, and it's often non-anatomic. So it'll cross fissures, or in the setting of patients who've had breast cancer radiation, you'll see something that kind of hugs the anterior lung near the anterior chest wall. What is a little bit trickier is when patients develop a complication from the radiation, a pneumonitis, because now you'll see a more extensive ground glass and consolidation, and you'll see some bronchial dilatation to begin with, and you slowly get more bronchiectasis, and you may see this persistent kind of consolidation. Contrast, IV contrast can be very useful, because if you see a focal rounded mass within that area, that's much more suggestive of recurrence. For me, I find it very useful to look at the borders of the consolidation, because oftentimes the borders are straight or they begin to get concave. But if you have convex borders in a radiation field, then we have to be really worried that that convexity may be from a bulging mass or so. Sometimes PET-CT can be useful, but that's more useful as you've moved further away from the treatment, because in the early setting, even a radiation pneumonitis will have increased uptake on FDG PET. And then very rarely, patients may go on to form some severe fibrosis related to the radiation therapy. But when we're evaluating these patients, we try to get a sense of what type of radiation they've had, what is the distribution of the abnormality on the imaging, and what's the shape. And I think by taking those three factors into consideration, you have a really kind of a fighting chance of being able to find an early recurrence when present in the setting of somebody who's received radiation.